We can begin, Tanya.
Okay, good afternoon, everyone. Thank you for joining us. And welcome to the Well Ahead Louisiana Education and Wellness webinar. Today's session will focus on nutrition awareness. And these webinars are for informational purposes only, and viewers should direct any medical related questions or personal health concerns to their healthcare provider. The Louisiana Department of Health, LDH employees, contractors, affiliates have no actual or potential conflict of interest in relation to these program presentations. The content herein is intended for general audience, not as legal advice. Laws and regulations take priority if there are any differences. Only LDH's secretary or surgeon general can give official statements. LDH cannot speak for other government agencies, and if you need any legal advice, you should consult a lawyer. To drive collaboration throughout the state that connects communities to tools and resources that can improve the health of our residents where they live, work, learn, play, or pray is the objective. And now I will pass it over to Dr. Lowenthal.
Well, thank you so much, and good afternoon, everybody. I want to welcome you to today's webinar on nutrition, as we are extremely fortunate to have two experts, Drs. Holston and Kimball, succinctly explain the importance of food as medicine and pressing issues in nutrition, especially pertaining to ultra-processed foods. In Louisiana, what we eat greatly contributes to poor health, resulting in 15% of adults in the state have type 2 diabetes. 39% of adults and 36% of children are obese. Nutrition contributed morbidities are key factors underpinning chronic non-communicable diseases. And this contributes also to Louisiana's rank as the least healthy state in the nation. But we know we can do better, which is why these presentations are so important. Well Ahead Louisiana is a chronic disease prevention and healthcare access arm of the Louisiana Department of Health. Our vision is to reduce the burden of chronic disease and to assure access to quality healthcare for all Louisiana residents. We work alongside with leaders from the community, faith-based organizations, local and state institutions, and the private sector to create environments in which everyone can be healthy. We believe that everyone has a role to play in connecting Louisiana communities to a healthier future. We are committed to educating and empowering leaders across the state with actionable steps to move Louisiana's health forward. Again, welcome to today's webinar, and I want to turn it back over to Tanya Stewart, our nutritionist. Thank you, Tanya. Oh, you're on mute.
Okay, sorry about that. Thank you. Today we have Dr. Denise Holston. She is an associate professor, state nutrition specialist for cooperative extension, and registered dietitian with the LSU Ag Center in Baton Rouge, Louisiana. For over 20 years, she has specialized in the translation, development, and dissemination of multi-level food access interventions and programs. She currently serves as the principal investigator for the LSU Ag Center Healthy Communities Initiative and the CDC's High Obesity Program. Dr. Holston's research uses dissemination and implementation of science to develop and integrate evidence-based practices into multi-level prevention efforts. As a qualitative researcher, her work focuses on formative evaluation methods to assess feasibility, accessibility, and barriers to chronic disease prevention, interventions that improve food security and expand food access in rural communities. All right, thank you. I'm going to set my timer here because I can talk about food as medicine for a little bit, just because it is emerging. It's a trendy topic right now, and so let's go ahead and get started. Next slide. Oh, back there you go. So for today's agenda, very briefly, we're going to talk about what is food as medicine. You may hear different terminology around that particular term, and so we're going to kind of talk about that. And then what does the evidence look like for food as medicine? What's going on at the national level? What's going on at the state level? And then some things that you might want to consider if you're working in this area. Next slide, please. All right, so let's define what food as medicine is, as well as the types of interventions that fall under the food as medicine umbrella. Next slide. The there's a couple of different definitions, but one that I like is food as medicine is a broad initiative that aims to integrate specific food and nutrition interventions within health systems to prevent, manage, or ameliorate chronic disease. And so from that definition, there are two key components. You have the provision of food in there, whether it's the form of a voucher, a CSA box, but it's also integrated within healthcare. Next slide, please. There are different types of food as medicine approaches. At the lowest level, there are policies, and then we have specific food programs that supplement income to purchase healthy foods. However, as you go up the pyramid, we have three main food as medicine initiatives, at least in the literature: produce prescription, medically tailored groceries, and medically tailored meals. As you see the types that go further up in the pyramid, the more specific they are. And so these different interventions are matched to the patient's level of dietary need and risk. So produce prescriptions are generally used more often. Medically tailored meals are typically developed by a registered dietitian with specific disease states in mind. So we might see it for cancer patients. We might see it with cardio or metabolic syndrome, but generally the medically tailored meals are designed by registered dietitians and are for those who are very sick and have multiple issues going on. What we know from the literature and the research is that no matter the type of food as medicine intervention used, you have to couple it with nutrition education and community engagement. We'll talk a little bit more about that. Next slide. All right, so again, I want to go back to medically tailored meals. And so that's the one at the top. And as I said, it's for complex disease states, generally designed by an RDN. And this is where we have the greatest evidence base in terms of changing clinical outcomes. However, not everyone would be eligible for what we would call a medically tailored meal. Next slide. Medically tailored groceries are, in some cases, boxes or food packages that have a range of foods in them. And this really varies by site, varies by the grant. But a lot of times they'll have produce, whole grains, beans, shelf-stable products. But you're assuming when using this approach that your clientele have the ability to prepare the foods and cook them. They have the supplies at home to be able to cook them and prepare them. And they have the ability, whether that's the energy level, if you have very sick patients, this could come into play. Generally, we might see these with diabetic or hypertension patients, and sometimes they may have not tested positive or screened positive for food insecurity. However, I outline this because those are some of the things in the literature, while we see that maybe a food, medically tailored groceries aren't taken up as much as they should. Next slide. Produce prescription are intended for individuals who have or are at risk of diet-related chronic conditions. And generally, we see these programs offered among rural, maybe food insecure or low-income individuals.
A lot of times the vouchers can be redeemed any place that fruits or vegetables are sold, not restaurants. However, sometimes the grant funding will dictate what foods can be purchased. For example, we participated in a grant where you could only have fresh fruits or vegetables. And so a lot of times you will program the vouchers to be able to interact with the point of purchase system within the state, and we work with Fresh Connect. But some produce prescription programs will can vegetables, frozen vegetables, any type of produce. What we have found, though, with the vouchers, credit cards are best, or ones that look like a credit card. They reduce stigma, and they reduce some of the anxiousness that comes with a store not being able to take the voucher, so the redemption of it. For it to run as it should, again, I look at implementation science and some of the contextual factors that will influence whether an intervention is successful or not, is that you'll generally see if it's not, because there was not a solid collaboration between the healthcare partner, the retailer, farmer, producer, and a trusted community-based organization. What is interesting about food as medicine work is that you have a lot of pressure points, and if you don't address all the pressure points, your clientele may not benefit fully from the intervention. Next slide, please. All right, so this is a little pop quiz. In the chat box, can anyone name the first large-scale food as medicine program? And you can place your guesses in the chat. I'm going to give you what looks like 15 seconds on my timer. Do we have any responses yet? And if you've seen my pop quiz before, don't answer if you know the answer already. Okay.
So far, there's none.
Okay. Maybe they're having a little bit of, the after lunch where you get tired. So I'll tell you, next slide. The first ever large-scale federally funded food as medicine program is WIC. And so WIC has been here a long time, and so it has evidence that built the foundation for food as medicine work. And so what we know from the foundational research for WIC is that WIC participation is associated with decreased preeclampsia, increased length of gestational and birth weight, decreased neonatal or NICU stays, decreased infant mortality, and the other findings that have come out of WIC, which I'm really going to talk about because this is one of the things that we really got to hone in on, is sometimes redemption and enrollment complexities can pose barriers to full participation and program impact. So remember, I was saying that earlier, but we're seeing that throughout. But I think what we've learned from WIC and the modernization of WIC can really help some of these food as medicine programs reach full realization. I'm tongue-tied today. Next slide, please. So in terms of what the research says on the effectiveness or return on investment for food as medicine programs, as I mentioned before, medically tailored meals have the strongest evidence for healthcare utilization and cost savings, especially for high-risk, high-cost patients. So those with cancer, those with cardiac events, some studies have shown the amount of ER visits for those type of cardiac events decrease after some interventions through medically tailored meals. Produce prescription programs have shown the strongest dietary intake improvement in terms of documentation, but much weaker and less consistent evidence for those clinical and hospital utilization outcomes, because there hasn't been a lot of randomized control trials around produce prescription, which we are calling for more now. However, as anyone can guess, randomized control trials are very, very hard and expensive to conduct. And so one of the things that we need, and they can take a bit of time, is to have longer term research funding to be able to really understand the evidence base around all of the food as medicine approaches. So what the research is telling us right now is all food as medicine interventions, they're valuable in terms of clinical and systems tools, but they really can't be a standalone right now for hunger, chronic disease prevention, or long-term food access. When we look at SNAP vouchers, we typically will look at that in terms of food insecurity, and food as medicine should be chronic disease prevention. All of those rely on a robust food system, and we do have some challenges within our food system here. And so that's why we know that food as medicine has some potential, but there's some issues that need to be tweaked in order for it to really impact outcomes related to disease states in clients. Next slide, please. Okay, so still going on and talking about what research is out there. Is the research that is out there is spread pretty wide in terms of some studies did 4 weeks, some studies did more long term, and the intensity in terms of the amount of vouchers range from very small, $5 to $270 a month. And so you can see that we really need to hone in on what is the dosage, how long do these need to last. Then we need to look at research with nutrition education, without nutrition education, even skills training, because one of the things that we're seeing in the research as well is that clientele who may be eligible for food as medicine interventions don't necessarily have the food literacy skills or the skills necessary to cook the foods in a way that is appealing to them. And so this is kind of what we're looking at, but we do have low participation rates pre to post to fully understand this. And that's why I was saying that there does need to be a little bit more funding allocation for the research side of it so that we can do due diligence on this initiative and see what works, what doesn't, what's the dosage, what's the length, and what are some of the implementation contextual factors that need to be tweaked in a real world setting. Next slide. I'm checking my time if you see me looking down. So what we don't know, like I said, the true impacts and outcomes related to produce prescription. Again, we know them a little bit more for medically tailored meals, but a lot of what we're seeing now, funding wise, is around produce prescriptions. Some are the medically tailored groceries. Again, future research needs to determine the most successful approaches to maximize participant redemption rates, scaling. Do we need to allocate more money for household size? I'm going to show you some of our research, maybe not. And we need to have enough of a monthly value for 6 months or more to see some of the changes in those outcomes. And again, that would have grant funding opportunities that would be much longer than we typically would see. So all that to say, we don't know what interventions work for whom and for how long. You're going to see different outcomes in an urban setting as you do rural. It's just the way it works. The rural areas don't have a lot of access points, so they're traveling much further. However, you may have what is in urban areas more of swamp and too much, but there are challenges there, as some of our audits have shown. Next slide, please. Okay, so taken together, I'm going to move through this, but it really depends on patient eligibility, what type of program that you're going to implement, y'all's capacity in terms of healthcare providers, community partners, and producers. And then these are some of the expected outcomes that you might see. Next slide. Okay, so what does it look like in Louisiana? Next slide. So our partners at the Department of Health and Well Ahead program have sister CDC grant programs. And since about 2023, we've been really honing in on vouchers for double up bucks and produce prescription under the food as medicine umbrella. So one of the first things that we did was a landscape review to see what was out there. One of the biggest findings is that Louisiana does not have a robust food as medicine network or produce prescription, to where as a state and as professionals in the different sectors working on this, we don't right now have shared goals or shared outcomes or even shared instruments that we can use to build the evidence for Louisiana. Next slide. Okay, so in addition to, I kind of repeated this, but there are key partners and key organizations that need to be involved. And we have some of those in Louisiana. However, more and more people are coming to the table. I talked about the framework, but there is a growing interest. And so with the number of interest, as a result, we developed what's called the Food as Medicine convening. Next slide, please. Before I move into that, the biggest recommendations that have come out from the landscape review is that you have to partner with local healthcare providers. You really need either a producer of the charitable food system in coordination and alignment. In red, I highlighted some key things that I am noticing throughout the literature in our own landscape review. What is lacking is participant input from the beginning. If you are designing an intervention that will target a set of individuals or a group, you really need to ask them, would you even participate in this? What are your barriers to participation? What are your barriers to actually using the benefits? What would be your barriers to actually using and consuming the foods that you get from this? And if you notice, there is a real lack of addressing participant needs, feedback from the community, tweaking those to be culturally relevant, and also educating others, the grocery stores, about this program so that they can expect clientele to come in. So we need to do a better job on educating and making the community aware, but also really understanding clientele needs. Next slide. All right, so what we're doing, next slide. I'm running out of time here. Now I got 4 minutes. We piloted this. We partnered with Share Our Strength. They had got SNP funding. However, they had a little bit of funding left over. And so we partnered with them, and households who had children in the household who were on Medicaid received, and Food Insecure, $40 a month for 6 months to redeem only fresh fruits and vegetables at participating retail locations. We did partner with Fresh Connect for the credit card, which most Walmarts, Albertsons are on this system. However, you can enroll others, including farmers markets. So what our goals were is to work with the healthcare partners, educate them on why this was important, how they can recruit and get clientele onto this. We assisted the participants with enrollment. We onboarded additional retailers and provided ongoing support. We had almost 400 recruited, and I think it was less than 3 weeks. Next slide. Okay, so the results, I'm not going to go into this too much because we're running out of time. You can see the demographics. We're going to share this, but I wanted to show you this study right here, which we just presented at the American Society of Nutrition. Again, we're looking at redemption factors and all of those other factors besides the actual, here's your voucher. Like, what is going on implementation wise? And we actually found that WIC participants redeemed significantly lower total amounts and a smaller proportion of available benefits when compared to non-WIC participants. So that was interesting because we assumed that WIC would have the same redemption rates or higher, but they actually didn't. And so we know that WIC participation was associated with lower utilization. We did find that household size really did not influence redemption, but we need to take a look at some of the institutional barriers of concurrent nutrition assistance programs. So WIC, the vouchers, how do we make it easier and more of a shopping? So we're really kind of digging into that. The other data that we're looking at is how far did they have to travel to go to a store, and did that affect redemption rate? So we're really looking at how you implement this to come up with best practices. Next slide. As a result of some of our initial research and the findings, again, the convening that we are partnering with for the Department of Health Well Ahead program. And at first, this was a very high level convening of the movers and shakers. Remember, I talked about pulse points that are needed at the table to make Food as Medicine really work and really impactful statewide. And so the Ag Center and Well Ahead Louisiana convened one in March, and then we did another one in June to try to start forming out the blueprint for what this looks like in the state. Eventually, this will become a community of practice or a network where anyone that is interested can participate. And then we'll also have a steering committee that represents the key stakeholders in what we call the food as medicine ecosystem, so that we can have more sustainable long-term impacts and programs related to food as medicine. If you are interested in not currently part of the convening and want to be part of the network, you can simply email me and I will put you on the list. Our next convening is September 29th. And so just so you know, we're meeting quarterly, and then we may meet more frequently if needed. Next slide. I think it's almost my last one. All right, Outlook, next slide. Okay, so Outlook, there's lots of funding opportunities, but I think all of us should look more long-term. And after we ride the wave of funding availability, food as medicine is always going to be here to stay, whether it's called food as medicine or not. The Ag Center can be here. I'm sorry for the font. It changed up a little bit to help you navigate food as medicine efforts. I'm not going to go through all of these because you will have access to this, but we can help train around food as medicine, identify partners. The nutrition education piece is really up to our local level agents because they do have other projects. And so in some cases, we can provide nutrition education, but it really depends on the parish. We can help you think through what evaluation looks like, especially in the formative areas. Next slide. As well as program communications in terms of really honing in on those clienteles and what they need. That's what a lot of our research has been around on that. So feel free to contact me. And if you are doing this type of work, we would be glad to help you and train you and provide support in that area. And I believe that is it for me. Next slide. All right, there's questions. And at the end of this, I have all my references and they're cool little tools that you can use. Thank you.
Great. Thank you, Dr. Holston. That was wonderful. Okay, so our next speaker, let's see, I'll turn my camera on there. Okay, so we have Miss Molly Kimball. Molly is a sports and lifestyle dietitian and a board certified specialist in sports dietetic by the Academy of Nutrition and Dietetics. A registered dietitian with a passion to make it easy for people to live their strongest, healthiest lives. As the director of lifestyle nutrition at Ochsner Health, Molly leads a team of lifestyle dietitians who guides clients towards achieving their personal fitness goals, disordered eating, and general health and wellness. As the founder of Eat Fit, a nonprofit initiative of Ochsner Health, Molly and her team of dietitians work with restaurants, markets, schools, and corner stores to develop and identify nutritious menu items. Eat Fit's dietitians work with nearly 600 restaurant partners across 6 regions in Louisiana to provide easy-to-access real-world education, inspiration, and resources on wellness and nutrition. Molly has co-authored 6 peer-reviewed journal publications related to the efficacy and impact of the Eat Fit Restaurant Initiative, as well as Eat Fit's Alcohol-Free for 40 Challenge. Molly is a nutritionist journalist who covers all things nutrition and wellness. She writes a weekly column for the Times-Picayune, New Orleans Advocate, and has been a columnist for Avenue Magazine since 2023. She's also been featured in weekly TV segments of Good Morning New Orleans. You can catch her podcast, Fueled Wellness and Nutrition, where she dwells deeper into science and stories to educate and inspire. Molly is the author of the Eat Fit cookbook, Chef-Inspired Recipes for the Home, and Craft, the Eat Fit Guide to Zero-Proof Cocktails. Molly prefers a good walk and talk with colleagues versus desk or Zoom meetings. In her free time, you can catch her creating functional pottery, a perfect antidote to technology and deadlines. And I give it to you, Molly.
Thank you. So I'm grateful to also be following the topic we just covered, because this sort of, that shows one side of what we're trying to encourage more of. Here's sort of the reasons why this is so important. We'll be talking ultra processed foods. If you think that like you know what we're covering here. There's things that I learned just this summer that I had no idea. As long as I've been doing this, like 27 years, there was things that were brand new to me. So I'm excited to share that, hopefully as new information to you guys. We'll go to our next slide. We can skip this one because we already talked about it. And I think, yeah, so if this is sort of the big question, and this is the question that I would say we ask ourselves. Those of us who work with patients, we have patients who are asking this. And usually when I am in a room full of people, I would say, like, raise your hand, you know, but if you think about what are some of those foods, we can put them in the chat. It doesn't have to be you. It could be a friend who struggles with this. But what are some of those foods that once you start, it does feel like it's impossible to stop? We'll give it just a second and we'll see if things come up in the chat. These are the things that I think about, like when someone's coming home in the evening and they're checking the mail, they're kind of doing those things. And we open that package. Are we having anybody in the M&Ms, chips, potato chips, cookies / chips, pasta? We'll take a few more, then we'll get into the why we asked this question. Ice cream with an exclamation point, Snickers, bread, Red Hots. That's a very specific one too. So one of the things that when I ask that question, one of the things we don't usually, I've never heard it, is, oh my gosh, Greek yogurt, plain unflavored Greek yogurt, can't stop eating it, or grilled shrimp, or whatever it is. It's not those things. The common theme of what was put into the chat just now are things that are specifically designed, and this is what we're going to be talking about, to light up areas of our brain. And that's what we're going to be getting into. And when we look at these, that carb, salt, fat combination that these have, it's not by chance. So we'll go to the next slide. So when we look at, this is something that I think is one of our key takeaways. It might be for yourself personally, it might be for people that you're working with. One of the biggest things that we think about is, think about how much people beat themselves up, how much they feel like failures when they start out with a game plan. We're going to make these healthy choices. I want to do, you know, they're mapping out maybe what that day or that week is going to look like nutritionally. 8 a.m. they feel solid, but by 8 p.m. they feel like a failure. And so when we understand that those foods, those that went into the chat and so many others, these ultra processed foods, they're specifically and strategically designed to impact our brains differently. They affect our brain's reward systems, our brain's pleasure centers differently. And we can go to the next slide. Those foods, when we look at it, when we say that pleasure system, that reward system, it's triggering that dopamine release, it's increasing our cravings. When we say reinforces repeated eating, what that means is it makes us want more and more and more. We open that package, we can't stop. Overriding normal fullness cues, that's a big thing, that we can have, we can consume so much more of these without getting those same satiety cues that we would get with shrimp or Greek yogurt or something else that would be like that. The trio, sort of that blend of these, is carb, salt, fat. So even though those foods in that list didn't seem to have a lot of, you know, they seemed very different, M&Ms to chips to ice cream, when we look at them all, they're all carbs. They all, with the exception of something like the Red Hots, but most of them are carbs with salt and fat. Even if we think ice cream, there's salt in that. Even with M&Ms, there's a little bit of salt in that. And so these are specifically designed to, let's go to our next slide, to hit what we're calling the bliss point. This isn't a term that I made up. This is a term that the food industry uses, and they spend millions, if not probably billions of dollars to achieve this bliss point. And what they're looking at is, when we look at that carb, salt, fat, but also texture, the color, all of these other things that are eliciting that craving response that we're feeling, they're spending so much time and money to create this. I think another real big thing to note here is these foods do not exist in nature. There's not foods with this bliss point that do exist in nature. They're all manufactured to appeal to our senses this way. I want to go to the next slide. And we'll stop here for a second. Does anybody know? I kind of want you just to put in the chat, yes, if you know what this is. I don't want a spoiler here. We want to be able to be dramatic with our next slide. But can you put in the chat, yes, if you know what I'm about to say next? But please don't put what it is. I'm gonna and if there's no yeses, we'll move on to our next. When I was running through this presentation with our okay, Ariel says yes, Tanya says I think so. When I was running through this presentation with our lifestyle dietitians, one of them said, "Oh, I think I know what it is. It's a fridge sig." And I said, "What?" And she said, "People call Diet Cokes fridge cigs." like and like they're craving it's like they're fixed, but it's a Diet Coke and they call it a fridge cig. So I was like, no, it's not a fridge cig. We'll go to the next slide here. This is what I learned this summer. This was in a journal. The American Journal of Public Health had a really incredible spread in the June issue, all on ultra processed foods, including a piece dedicated just to this. If you can put in the chat or raise your hand or any of this stuff, is this like, this blows my mind. Back in the 80s, tobacco companies, R.J. Reynolds, Philip Morris, bought out Nabisco, what was then called General Foods, Kraft. So if you think about it, back in the 80s is really when we started to see a significant shift in how these foods were marketed to us. The Saturday morning cartoons, the characters on the boxes, and so when I had no idea that these companies were owned by tobacco companies. Some were shorter lived, 9 years or so, some were almost 2 decades. And so when the tobacco company bought into the food industry, they're bringing so much expertise that they already have. We can go to the next slide. They know how to work with flavor chemistry, how to optimize a product to appeal to our senses, to appeal to our emotions, how to market, that marketing psychology that's so effective. They may not have known food specifically, but they knew all of these other ways to appeal, to make us feel really good and to feel like a product is desirable. When you combine that with that bliss point that lights up these areas of our brains and wanting more, 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 it's really no surprise that these foods become such a struggle for us. Let's just pause for a second. I'm going to see if y'all can, I don't know if we can do a hand raise or a holy smokes in the comments here. I was waiting for an audible gasp whenever I present this in person, but since I'm not really seeing all of y'all, I'd love to get a little bit of just chat feedback. Thank you. Yeah, that's about how I felt. I think it's one of these things that as I've interviewed different researchers who study ultra processed foods, physicians and also researchers in the you know, obesity medicine space, one of them used the phrase, "I don't want to be manipulated to." And so when we understand more about what's behind the ultra processed foods, including something like this, it helps us look at these things a little bit more objectively, and it takes away a little bit of that shame and that blame that we may have of feeling like, why can't I get it together? Why do I feel like I don't have the willpower that I think I should? And so I think that this helps to kind of put it in a new lens. We can go to the next slide. So there's a category for this. We'll go to the next slide. When we're looking at ultra processed foods, there's a lot of different definitions. And there's a little bit of a debate of what makes a food ultra processed. So we'll kind of streamline it here. Refined starches, industrial oils, flavor enhancers, things like emulsifiers, a lot of times synthetic food dyes, things that we do not have in our kitchen, things that don't exist in nature, all wrapped up into a product for us. Designed for convenience, designed for hyperpalatability, like we talked about earlier, and also a long shelf life. We'll go to the next slide. There's you may have seen NOVA classification, and I'd seen this. As I was presenting on this and researching for it, I was like, what does NOVA stand for? It's not an acronym. It's just a word that the researchers made up who pulled this together. So the 1, 2, 3, 4 classification, I think, is just an interesting way to think of it. Lauren Berry, one of our dietitians on our team, was sharing with me a talk that she heard, and I thought this is a really good example, and I'll try to remember it because I didn't refresh myself right before this. But minimally processed would be just an apple. Or minimally processed are the things. I think it's important to note that even nourishing, nutritious foods are processed to some degrees. Oats, whole grain bread, these are things that they're still processed. They're not exactly as they came to us in nature. So either or none or minimally processed would be that apple. Something like just baked apple crisp or applesauce with no sugar added would be something like a processed culinary ingredient. Processed might be that applesauce with sugar, and then that ultra processed is going to be like that McDonald's what do you call them? It's like an apple pie. Yeah. And so that would, those are things that, yeah, it all starts with an apple, but our level of processing can really vary there. So we'll go to the next slide. One thing too that I really like to, as we're talking about ultra processed foods in this conversation, I think it's really important to note that or be cautious of that health halo. And so when we're working with patients, when we're working out in the community, there's a lot of information out there and a lot of I think the phrase is like a red herring that can kind of distract us over here. So if you've got a Dorito and that Dorito is now seed oil free, it's still a Dorito. There's a burger shop. It might have been Smash Burger, may not have been, but it was one like that. You walk up to the door and they have a big sign on the door that says no seed oils inside. Well, it's still a burger on a white bun or a cheeseburger or a double cheeseburger with fries and a sugary soft drink, So the fact that there's no seed oils doesn't necessarily make that food healthy. And so I would say same, Skittles, candies without the red hots that someone put in the chat, you take the synthetic food dyes out, they're still just candy. So making sure that we are aware that some of these modified versions or taking something out or adding something like protein to an otherwise still high sugar Pop-Tart or cereal doesn't necessarily, they may be a smidge better, but being mindful of that health halo. Also kind of going back to the food industry, that food industry, they're really smart. They're spending a ton of money on this. And when we look at things like the dietary guidelines and the things that are coming into the dietary guidelines, an emphasis on protein and an emphasis on decreasing ultra processed foods and synthetic food dyes, food makers see this and then they start hopping on the bandwagon for it. So just being aware that overall pattern is what matters most, not one ingredient either vilifying or giving that health halo to a product. Our next slide. So there's been a lot of research. There's been a lot of research in the past decade, and especially in the past 5 years. I think I have it on here, but if I don't, Dr. Ashley Gerhardt is doing a lot of really incredible research in this space. Also, Dr. Erica Lafata, and they and their teams, and others, but they're two that I feel like every time I'm reading new research on ultra processed foods, one of those two is associated with it. So we're seeing more research. We're having a better understanding of what happens with these ultra processed foods and in our mind, our body, our brains. There's a public awareness, again, usually for the better, but sometimes it can make things confusing and it can confuse the public on, well, what is healthy now? And greater demand for transparency. People are used to seeing and understanding a little bit more about maybe what's in something than before. And we're also seeing that, and we'll go to the next slide, when we're talking about ultra processed foods in this conversation, it goes so far beyond obesity and diabetes. And so, yes, while those are things that maybe are the first that pop into someone's mind as they're hearing these, especially like the layperson, there's so much more here. I really want to go down to like line 4 that I have in this list, depression and anxiety. When we look at the impact that ultra processed foods has on our mood and especially anxiety, and it's creating that cyclical effect. When we're feeling anxious, we're feeling nervous, we come home from a day, we're having that, that feeling of stress, of pressure, that noise in our head, that spiraling, and then we open the box of fill in the blank, that stuff you put in the chat. And once we're having it for that moment, it's eliciting that response that is helping us have that temporary distraction, the dopamine release. It's having that temporary calming effect. But when we look at what's happening in the longer run, a high intake of these ultra processed foods is linked to higher incidence of anxiety, and depression. So I think that's really important when we're looking at things like all of the whole body, and we're looking at what's going on with an increased prevalence in these. And there's so many other things that we can address with it. But if that core foundation and sort of the building blocks are still primarily made up of those types of foods, it can make it really hard for these other treatments and other benefits that are there for people, for those to be as impactful. So I think it's when we start thinking about and tying in what we're eating and how we're feeling right in the moment, I think that correlation can be really strong. It can be a lot harder for someone to say, I'm going to dial back on these foods because of what it's going to do to my blood pressure in a few decades, or there are things that seem so far removed, but how it's leaving me feel right now or this afternoon can be a little bit more of that right now motivating factor to rethink or adjust how much of these foods that we're reaching for. So going to our next slide, when we look at what we can each do, I think some of this I would take it to for us personally. I would also say the patients we're working with, the communities that we're working with, shaping our environment, focusing on that overall eating pattern, educating about what to look at on labels, and things that can look one way on the front of the package when we turn it over, what's actually in these foods. The number four here, I feel like on a personal level kind of mirrors number one a little bit, but keeping these nourishing foods visible and convenient. And it's not, a lot of times, depending on who all is in the household, it can be a hard thing to navigate of what are we keeping in the house or not. And so I think that's going to be a key area too. And aiming for progress, of course, not perfection. So I'd say these are things we can do personally. There are things we can encourage patients, and when we're out in community, talking with them as well. These are also things that on a bigger scale, those of y'all who are on here, the work that you're doing, you have influence in your space. And so as much as you can use the influence in your space about what is served in or what's available in your office kitchens. We had somebody in a HR, she works for a law firm. She has HR for a law firm, unrelated to health or wellness, but she cared, and she cared about what the employees of the law firm, how they were nourishing their bodies. They have candy in there. So she got these green glass containers, and those were what she had all of the candies in, because they don't look as attractive through that green glass. Then the healthier snacks, they had out visible, you could easily pick them up. So learning and just thinking even the smallest things that we can do in our own space. We'll go to the next slide. This is something I wanted to share with y'all just really quickly. It's something that we're really proud of in this. Oshner as an organization last year committed to a food service wellness commitment where the increased visibility of healthy foods, the Eat Fit foods, are not only higher visibility across the Morrison cafeterias, Coke machines, soft drink machines, and food vending machines. So higher visibility. By the end of this year, it'll be about a 50% product mix. They're also charging half price for these in the cafeterias and those drink machines. The food vending machines are about a 25% discount, but charging less for these healthy foods, and we're seeing the sales numbers go up. So if someone's going in that fried fish or the grilled fish, they're trying to make that decision, and the grilled fish is half price, it's helping to remove that barrier. There's so many barriers for people for eating healthfully, and that's at least helping to improve that visibility, the access, the affordability as well. We can go to the next slide. These are the podcasts. I think we'll all have this slide deck. So we'll go to the next slide. These are two podcasts with researchers that I mentioned who are just spectacular. The Eat Fit app, tuck this away as a resource. I didn't share with y'all a lot about Eat Fit at the beginning or really anything, but it's free. We work with restaurants. We don't charge the restaurants. We have an Eat Fit team member in 6 cities across the state. We want to work anywhere where food is served. We want to work with them. And so on the app, you can type in your zip code and it'll geolocate what restaurants are near you that are Eat Fit partners. You can find our Eat Fit criteria on the website, but we also have in here recipes. And what's, I think, a really valuable couple of tools, we have a brand specific shopping guide. So not just a low sodium salad dressing, but which salad dressings, which breads, which crackers, from stores ranging from Walmart to Whole Foods and everything in between, our local grocers, et cetera. We also have a shopping guide that's dedicated specifically to independent local grocers. Then our Wellness Bites newsletter, also free, and we have that goes out every Monday. Tons of information, resources in there every week. So we have the QRs on these, and we can also, if you have trouble finding, we can help you with those. But the Wellness Bites newsletter is also just fun. We put fun videos and stuff like that in there. And then the couple of more resources I want to share with y'all. This is something that is going to be going out in a couple of weeks. If y'all have seen the new requirement for physicians, physician assistants, and registered nurses to have an hour of continuing education. It was every 2 years. Now I think it's every 4 years, but we're hosting that. We're providing that education for them, and it'll be rolling out in September. And with that, we have a companion resource guide full of so much information. We're covering like 15 different topics in that hour, just fast, rapid fire. But one of those topics specifically is ultra processed foods. So we already have this on our app. We did have to change the link. So if this QR code, I should have checked it, doesn't work, once you get to our app and you go to the guides, you'll see guides on there. You'll be able to see the the companion resource guide, and then scroll down and you'll see it. So lots of resources here. And then, our contact is on here. So if there's anything that you're like, hey, we don't get to in questions, I know that I'm saying we've got like 9 minutes left for questions. Y'all can always reach out to directly.
Thank you, Molly. That was wonderful. Lots of wonderful information. And we do have two questions. One question is are there any documentaries that you'd recommend for middle school age children to watch?
I would love to know that. I don't know. And I think when I just saw that question, I was like, wow, that's really like a great question. I don't have one off the top of my head, and I would welcome if others want to put in the chat, or other colleague, if you have any ideas, Denise.
That's a good question. I don't with kids for youth.
Okay.
Okay, we'll come back to that. So if anybody knows, let us know too, if y'all have one.
And then I think we had one more. How would you two recommend navigating food at a time where we're seeing daily food recalls?
Denise, I'll let you take this one.
Okay.
And after.
So yeah, we've actually had that question come up a good bit. Oh, and I don't have my camera on. Because of food is medicine, we're going to have produce. So I have not personally changed the way I eat, but I'm more careful and knowing where my fruits and vegetables come from, but also washing them and using the basics food safety practices that we typically educate folks on. I right now, because there are so many, but it doesn't cover these different foods. Personally, I'm not eating vegetables that are already prepared and fresh, if that makes any sense, just to kind of lower my risk. But I don't know if you can ever 100% be safe from things, but I certainly know I'm kind of weighing the benefits and the risks, and stopping consumption of fruits and vegetables is more a risk for me. So, but I'm going to turn it over to Molly to see what she thinks.
Yeah, I agree on that. I think there's also such an uncertainty of where it could be next that what would you do? Like, it would be hard to say preventatively, I'm going to change or not have these foods because of a potential. I think consuming those foods, the benefit of it is going to outweigh what's the potential for risk. I think just, staying tuned in, staying dialed in when there is even the beginning whispers that something that might be, an issue, especially maybe somebody who has a compromised immune system, or that also has other reasons to specifically, like, not that anybody wants to have, the sicknesses that we're hearing about and the drama with that, but knowing that there's some people who have, again, compromised immune systems, elderly, who are going to be particularly vulnerable, really keeping, an ear out and being cautious for this. But I would say it's not something I would want to guide people to avoid in general. There's a comedian who I really like, Josh Johnson is his name, and he had something, he has fun little clips on his social all the time. And he did a whole bit about, you know, it's the produce that's going to kill us. Like he's like goes on the whole thing about all the sugar and all this stuff, but then it comes back to like it's that. And it was a tongue in cheek, of course, but it's so unfortunate that those are the foods that are in the media and what we're, I mean, not even just in the media, that those are the foods that are causing these effects. It's sad. Why couldn't it be Doritos or Skittles? Yes, he's from Alexandria. Love Josh
Mhm.
Johnson.
Well, great. Thank you. And thank you for those questions. We'll now turn the floor over to our Bureau Director for closing remarks.
Well, I want to thank our speakers today. This was for their excellent presentations and the savory food for thought, make us all hungry for more knowledge and systems changes, which of course we are all part of. And so we appreciate everybody joining us on these webinars. We appreciate what we all can do as individuals, as part of communities, and working all towards a common goal to improve the health of Louisianans. So please, if you have additional questions, send them to us. Please contact us at Well Ahead, and we look forward to seeing you in future sessions. So thank you all, and thank you, Tanya, for being our MC today.
Thanks, Al. Thanks for
And-
having us.
You're welcome.
Yeah.
Thank you.
And these are
My pleasure.
recorded and they are available after, so you can share them widely, and we will make sure that you get all the information that has been shared with us today. So thank you all.
Thank you, ladies.
Thanks, y'all.
Thank you.